We are honored to have Dr. Hagen Kennecke as a presenter with the topic of carcinoid cancer, what you need to know. I'd like to introduce our presenter. Dr. Kennecke is a medical oncologist and medical director of GI Oncology at Providence Cancer Institute and associate member of Child's Research Institute in Portland, Oregon. He has worked passionately to improve the treatment, education, and outcomes of those affected by colorectal and neuroendocrine tumors. He is an active clinician researcher, the recipient of numerous research awards, and has authored numerous guidelines on the treatment of neuroendocrine tumors. He is a member of the U.S. NCI GI Steering Committee and is the immediate past chair of the U.S. NCI Rectal Anal Cancer Task Force, and he has worked extensively within the neuroendocrine community, including NANETS, Carcinoid Cancer Foundation, and Healing NETS. Please welcome Dr. Hagen Kennecke.
Well, good morning, everyone, and thank you so much, Gemma, for the introduction. It's a pleasure to get to know Portland. I moved here just 6 months ago. I did actually some of my training here at Legacy Health Systems, and then I moved back to Canada, Vancouver, British Columbia, where I spent much of my clinical and academic career, and more recently have come down to join the Child's Research Institute and the Portland Providence Cancer Institute. I'm located on the east side for those of you who know the campus, and there's also a west side clinic, the St. Vincent. So my passion is GI cancers, and I treat a lot of patients with colorectal tumors and neuroendocrine tumors, as well as pancreatic and hepatobiliary cancers and hepatomas. Today, I really wanted to focus on a more rare cancer, but one that is relevant because it has grown, and it is quite an unusual one that I've worked with extensively in the past. So I really appreciate the opportunity to talk to you about that. I'm going to start sharing my slides, and so we'll get started. Here we are. And again, don't hesitate to enter questions in the chat box that we can get back to then. And just can somebody let me know if you can see my slides now?
I see it.
Okay, great. Thanks, Brian. All right, wonderful. So we're talking today about a type of GI cancers called neuroendocrine tumors. And the overall objectives are to really understand what these tumors are, as well as theranostics and why it is important. I'm going to introduce that term and consider the role of treatments, including surgery and Octreotide and Lanreotide. And finally, to review a very specialized therapy for these cancers that we have just introduced 3 months ago. That's one of the first things I did when I came to Portland Providence Medical Center to launch this new treatment program. So just as a primer, we put some questions in the chat box, and hopefully you can all answer them. But really kind of broad question, have you ever heard of colorectal cancer? I hope so. It is the #2 most common cancer in North America. Have you ever heard of neuroendocrine cancers? And another word for neuroendocrine cancers is carcinoid cancers. Third question is, have you ever had a colonoscopy? And number 4 is, please rate your knowledge about neuroendocrine tumors and /carcinoid cancers from 1 to 5. Number 5 is, please rate your knowledge of these NET cancers in terms of diagnosis and prognosis, rate from 1 to 5. And then finally, we're going to have an open-ended question about, do you know that there are many targeted treatment options for NETs? And finally, we really value your feedback. What else would you like to learn about this cancer? And of course, you can use the chat box. So why are we talking about NETs? Neuroendocrine tumors, also known as carcinoid tumors, they are becoming more common. And this is a publication from 2017 describing overall the incidence. And incidence is a number we just use to describe the frequency of new diagnosis per 100,000 people in the population. And as you can see, it's expressed as a fraction. The frequency of neuroendocrine tumors of multiple different origins is generally increasing. So you can see that neuroendocrine tumors can start in many different organs, including lung, stomach, small intestine, cecum, appendix, colon, rectum, and pancreas. And you can see the trend, at least in this study, in this United States study, the tumors have all been increasing in frequency. Most commonly, these tumors arise in the rectum, which is relevant because they can be detected on colonoscopy, as well as the ileum, which is the small bowel. One final thing is that we talked about incidence, but we also know there's another number called prevalence, which is really the number of patients living with this cancer. And there's actually over 2,000 patients living with this cancer in Oregon State right now. So what about in other countries? The Koreans have done a really large study. They have excellent databases, and so this was one area of interest for them. And they recently published, well, actually it was almost 9 years ago, they published the frequency and increase in diagnosis of neuroendocrine tumors in their country. And as you can see, their results were a little bit different than in the United States, that although they do describe a fairly fairly consistent, representation of these tumors throughout the population, it's only the rectal neuroendocrine tumors that were increasing in their study. In terms of, we always want to know, how do people do when you are diagnosed with this cancer? And this is a presentation of what is the median overall survival, which is a really important term that we use in cancer, which is the average amount of time that you live after you're diagnosed with this cancer. So that is really an important thing for people who have a diagnosis of a malignancy. So this is the average amount of time that patients with different types of neuroendocrine tumors, appendix, cecum, colon, liver, lung, pancreas, rectum, small intestine, stomach, and unknown live. And as you can see, patients who have localized disease live the longest generally. That's the dark bar, and this number is expressed in months. So that's actually quite a bit of time. That's about 30 years, 35 months, over 30 years. So I think one message is, if you catch this cancer in a early stage setting, then the majority of them are cured. So you live as long as you would if you didn't have the diagnosis. However, it's only if these tumors are diagnosed in the advanced setting that the survival is shorter. And in some cases, if they're diagnosed with a locally advanced setting, for example, locally advanced lung or pancreas, that's when the survival is lower. And that's really why screening with things like colonoscopy is so important. I spent 17 years in Vancouver, Canada, and we did a study of patients with rectal neuroendocrine tumors in the province of British Columbia. And we looked at how well they did and what kind of treatments they received. And over a course of 10 years, just under 10 years, we identified a total of 60 patients with this diagnosis and found that most of the patients with rectal neuroendocrine tumors had rather small tumors. Most of them were successfully cut out by just an excision as opposed to a big surgery, and most of them were cured. So this was an important finding for us because it told us that we don't always need to do a really big surgery to cure these cancers. And that's important because you don't want to have to undergo a big surgery, lose your rectum or lose a large amount of bowel in order to successfully treat your cancer. So we found that people with early stage disease, stage 1, 2, had a very, very high survival, even if they were treated with excision. Of course, if they had more advanced disease, stage 3 or 4, their survival was shorter. So that's really what we call the epidemiology of the tumor. What about the diagnosis of it? And this is kind of a really novel concept, which is called theranostics, which is a kind of a merger of the concept of a diagnosis as well as a treatment. So it's a bit of a play on words. And theranostics really refers to a diagnostic test that can not only find the cancer, but can also identify whether they're going to benefit from a targeted treatment from it. And in this case, in the case of neuroendocrine tumors, patients that have a certain target on them called the somatostatin receptor, they will light up on a very special PET scan that we offer at Portland Providence Medical Center called a gallium-68 dotatate scan. And so you create this very specific peptide that has a marker on it, which is called gallium, and then you give it to the patient intravenously, and you do a scan. And if they light up, that means that they have this tumor, and if they don't light up, that means that they don't have this cancer. So that's a very important diagnostic consideration. But the other important thing is that if indeed they do light up, then we can use a different type of radiation particle to treat them at a later date. So that's really kind of the big concept that we apply is very important in this specific cancer. And I'm going to tell you a little bit more about how that looks in clinical practice as we go through the presentation. And so here's some more detail about the concept. The target is the cancer. The vector molecule is what sticks to the cancer, and attached to the vector molecule is this particle of radiation. And if the cancer is there and it sticks to it and it lights up, and if it's not, then the body just eliminates it, and there's no and it doesn't light up. So some different theranostics treatments and diagnostic tests that we have now approved in the United States over the past 4 years are a gallium-68 dotatate scan, which is a very special PET scan. It's also known as NetSpot. We try not to use the commercial names, but sometimes they're easier to pronounce. But the gallium-68 dotatate scan is the NetSpot, and that's was approved in the United States in 2017. In 2018, a lutetium 177 dotatate was approved, and which was called Lutathera. So that's the trade name for this. And just last year, another diagnostic test called a copper-64 dotatate scan was approved, and called the DetectNet. So let's go back to the beginning then. How do you get diagnosed, with a neuroendocrine tumor? Well, most commonly, because most of them arise in the large or small bowel, as we saw earlier, a colonoscopy is really, really key. So we know that the new recommended age for screening, I don't know if this were a live meeting, I'd ask the audience as to what they are, what that age is. If you know it, you can put it in the chat box, but it's actually now 45. So the age recommended to start colonoscopy screening now has been recently, as of 2 years ago, decreased from 50 to age 45. So everyone should get a colonoscopy approximately every 10 years to detect cancers like colon cancers and neuroendocrine tumors early. The small bowel tumors are a little bit harder to find on the colonoscopy. The colon, it really looks at only the rectum and the colon and not the small bowel like the ileum. So sometimes we have to do additional tests like a capsule endoscopy. CAT scans are really important. MRIs we use for rectal cancer. And then we talked about these very specific theranostic tests called the gallium-68 dotatate, the net spot, and the Octreotide scan. So let's look at what some of these scans look like. And this is for the situation where we're looking for the cancer in the patient's whole body. Well, when I started medical practice, we used to use the Octreotide scan, which was a commercial test, and we gave a nuclear agent to the patient, and then we looked to see whether there was any tumor. And it was a very inaccurate test. In this particular patient, on the left two screens, there's the whole body view, and there's also the CT scan view. And you can see in this is the patient's liver, and this patient's, you can see a little bit of, actually this image here is the bowel, and you can see a bit of tumor lighting up. It's a little darker here than in the other areas of the body. And then you can see on these superimposed images that it lights up, it's brighter. However, with these newer scans that we've been using over the last 4 years, you get a much, much more accurate picture, and you see things that are visible that simply were not visible before. And sometimes you actually see tumors that you didn't see on any area of invest in any modality. So this is what we now can see. And if you can't see it, then you can't treat it. But if you can see it, then you can treat it. So that's why it's really important. So when at my last institution in Virginia, I was at Virginia Mason in Seattle, where we saw a large population of patients, and we treated them with all these patients. We did a gallium-68 dotatate scan once it was improved in 2017. And then we looked at how they did, what our findings were in the first 101 patients that we offered the scan. And what we published was that this scan, just by doing it, changed the management of these patients in 30%, 37% of the time. So that's a really important concept, that not only can we see these tumors, but we actually do something different when we see them properly. And so here are some examples of what this scan looks like. And this is a conventional CAT scan, and if you use your imagination, you can see a little bit of stranding and a little nodule here that you're like, well, it's very small. Anything less than a centimeter on a CAT scan is very difficult to characterize. But if you do the PET scan, in addition to the CT, you all of a sudden see that this nodule lights up, which means that it actually is a cancer. And then the same thing in this one here, you see all kinds of nodules here that you don't really know what they mean. But if you do the PET scan version, all of a sudden this nodule lights up. So that's really the strength of this study. And now when we see this, then that allows surgeons to remove it, or patients to receive treatments to target those tumors. Here's another example. Hepatic metastases are easily seen with this scan. And here's the net spot compared to an MRI. MRI is, a very expensive and detailed test that we use to look at tumors in the liver, including hepatocellular carcinoma, hepatomas, liver cancer. But even compared to that one, here we see a lesion on MRI, but it's kind of hollowed out, and we're not sure whether it's a viable tumor. And when you do a net spot, it actually lights up, and no other areas of the liver lights up. So it really tells us that this is a tumor that we need to cut out. So when you do all these scans, you actually find cancer in places where you never thought you would find it. And this is a study I published with a fellow of mine who came down to see me in Seattle, and she actually now works in Vancouver, but she did a study, and we looked at whether the impact of this scan and finding metastasis, so cancers in the heart. And it looked like of all the 123 patients that we did these scans on over the course of a year, 3.3% of them had metastases, so a nodule in the heart. And so that's the one here on the left, and on the right you see this arrow that points to the cancer that had made its way to the heart. But not only did we demonstrate that, but we demonstrated that in spite of having a tumor in the heart, we were able to safely and successfully treat it with the Lutathera. So because sometimes in the past there's been concern about, if there's a tumor in the heart and we treat it, will it cause a dysfunction of the heart? But we showed that you can successfully treat these tumors in spite of them having spread to the heart. So let's go back to the management of this cancer. What's the best way to manage them? So surgery is the most important way, as I showed in an earlier slide, and most patients are able to receive surgery, and that's a really important way to successfully treat the tumor. Once that's done, we really do not need to do any additional treatment. There's some role, for example, in some cases, in some other cancers, for example, that have had cancers removed, to offer chemo or hormone therapy. That is not the case with this treatment, not the case with this cancer. What is recommended is that they do need a special CT scan every year for up to 10 years. And that is really very different in this cancer than some other cancers where you really only need to do scans up to 5 years. And we do a very specific CT scan, which is called a triphasic scan. And if there's any abnormalities, then we do one of those fancy net spot scans that I just showed you about. There is some roles for blood test and urine test, and we discuss the role of those with our patients. What about if in the situation of an advanced neuroendocrine tumor? So those are ones that we can't successfully remove with surgery. What is the role of treatments for them? So obviously, these are patients with advanced tumors that have spread throughout the body, similar to what we've seen on some of the scans that I showed you. They could have tumors in the liver, they could have tumors in the abdomen, they could have tumors in the bones. So what can we do for these tumors? So what I listed here is the first thing we always talk about is, can we do surgery? So even though it's spread beyond where it started, is surgery still possible? So we always work with surgeons very closely and ask that question, and then we make a decision in a tumor board as to whether or not this is something we should discuss and offer to our patients. Other treatment options are Octreotide and Lanreotide, and those are very specific medications that stick to the cancer, kind of like hormonal therapy. They bind to the tumor and prevent it from growing. Other examples are intra-arterial therapy, PRRT, which is what we'll talk about at the end of this presentation, which is also called Lutathera. And there is a small role for chemotherapy and small molecule therapy that can be used for these tumors in some situations. So let's talk about the first treatment option. The first treatment is the area of is surgery, and as mentioned, these tumors do like to go to the liver, and this is a major area of concern, and I'll explain to you why that is. Many of these tumors start in the bowel, in this small bowel or large bowel, and all the blood from the bowel the first place it goes is actually to the liver, because that's the job of the liver, is to absorb the nutrients that come in through the body. But the cancer cells can spread to the liver that way too. And so that's why we often deal with treatment of cancer in the liver. And there's a lot of experience showing that even if the cancer has made it to the liver, if you do the surgery to the liver in select patients, many of them can live a long time, and many of them actually feel better. 95% of patients who had liver surgery actually felt better after their tumor was removed and when they had surgery. However, I mentioned about, that we take these patients to tumor boards to decide, who can have surgery and who cannot. There are certainly some situations when we really shouldn't be doing surgery, because then it is more harmful than beneficial. And those situations are generally when the tumor looks quite aggressive, when there's tumor not only in the liver, but outside the liver, and if the surgeon cannot remove all of the cancer in the liver. And that's really when we're considering alternative therapies. And that's what I'm going to talk about later. Just a slide I put in. I know Twin suggested that it was a little bit too technical, but I'm just going to make one comment that these are really unusual tumors, and that some of them can really secrete hormones that when you cut into them or when you start to destroy them with radiation or other treatments, then they can secrete a whole bunch of these hormones, and we need to be prepared for that. So it's called a carcinoid crisis. I don't think you need to know any more about this, but it's important that the doctor that you work with knows that this is a risk and that they take the appropriate precautions so that the hormonal crisis doesn't happen. And what they do then is they treat the tumor with Octreotide and Radionuclide so that it doesn't have the ability to secrete all those hormones. So these are the things that are given in either Octreotide or Radionuclide, and those are proteins. This is the human version of it, but there's also a synthetic version of it called Octreotide or Radionuclide, two very similar competing pharmaceutical products, and we use them to actually control the cancer. So that's really all that I wanted to share here with these slides, is that there are some complexities about these cancers that are not present with other cancers that it's really important to know about when you treat them. So in the final part of my presentation this morning, I wanted to talk about this new treatment that we use called Lutathera. That's the trade name, in order to target these cancers that we can't otherwise remove with surgery or otherwise. And this is the proprietary name, and it's called Peptide Receptor Radionuclide Therapy. And what it is that it's an intravenous treatment, and it's a treatment that's given for a total of 4 doses only every 2 months. And sometimes we extend the interval a little bit further. So what is this treatment? So this goes back to the Lutathera, the theranostics concept that I talked about at the beginning of the presentation, where we use a certain peptide to a linker, a vector, to stick to the cancer and attach it to that a particle of radiation that then kills and destroys the cancer. So this is a bit of a cartoon of it, but here is the peptide that is given intravenously to the patient and then sticks to the cancer. And this is the radiation particle that's attached to it and embedded in it, in this case called lutetium-177, which emits a very certain type of radiation that only goes for 2 millimeters, but it's enough radiation to kill the tumor. So that's the very, very specific. It's kind of like a liquid radiation form, but the radiation only goes to the tumor. So this is how it works. This is the program I started in Seattle, and I also started it here with our nuclear medicine team in Providence, Portland. Patients come in, they're ambulatory, a nurse starts 2 IVs, and we give them a little bit of amino acids to protect the kidneys. And then we give this treatment called lutetium-177 dotatate. The other name for this is Lutathera. Excuse me. During that time, we have to be a little careful about radiation safety, but within an hour, that treatment is finished, and we give them patients a little bit more fluid, and then they go home. So it's a very straightforward treatment in the sense that we can give it as an outpatient, but it is actually quite complex because we have to order this dose and make it, especially for every patient, right before they come in. So there's a lot of complexity about giving the treatment and making sure the patient gets the right dose. This is some background. This is some of our experience with the treatment. The treatment actually comes from New Jersey. It's shipped in these lead cases, and it comes in this vial that we then attach needles to, and we put fluids in, and then the fluid forces the radioactive liquid out into the vein of the patient. This is a video that you can find on YouTube that one of my first patient in Virginia Mason in Seattle did, describing her experience with the treatment, because this was at that time, a very new treatment initially in 2018, and it really helped a lot of patients understand the treatment and what's involved and how it can benefit them. And so we ended up treating quite a large number. We treated over 100 patients, 120 actually, with this treatment in Seattle, and we've really started treating a lot of patients here as well. And here's some outcomes, experience of what this treatment does. I talked about doing these special scans to find the cancer so that we can treat it. So this is a scan, those special scans that you saw earlier, with a tumor in the liver before the treatment. And then after the treatment, generally about 6 months after, we repeat the scan, and we can see that the tumor is no longer there. Here's another example, before and after scans. And this is an important thing because you want to know whether the treatment worked. And this very special scan allows us to determine that. Here's another example of before and after. Before you see lesions throughout the liver, and after you see much less. You still see a little bit of a shadow here. I will say that this is a very, it's not a common cancer, and it's a very specific treatment, but within the next 3 months, this very same treatment is going to be approved for prostate cancer, for the treatment of prostate cancer. So stay tuned, you're going to hear a lot more about it. This is some experience that we had in treating using Lutathera, this very specialized treatment for patients with other cancer that also have these molecules on them. And they're called pheochromocytomas and paragangliomas. They're super rare cancers, but they just happen to also have these they're also hormone secreting cancers. So that's what the similarity is. But they also have this target on them. And this is a fella that actually came down from Anchorage, and he was really sick from his cancer. When we gave him his initial dose, and over the next 6 months, he really, really responded well to the tumor. What's remarkable, and you can see that here, is that these patients with the pheochromocytomas and paragangliomas are actually quite young, and many times they have a hereditary syndrome. So it was really meaningful to us to be able to offer them this treatment. So in closing, I wanted to, I would like to share that, neuroendocrine tumors, I hope I taught you something about them. They're no longer rare, as you can see, both in the US nor in Asia. The rectal nets are increasing particularly, and they can be detected on colonoscopy. And there are many targeted treatment options for neuroendocrine tumor. Surgery is generally the best when possible. The treatment of these tumors is highly multidisciplinary. It involves a big team. So everyone needs to know how these treatments work. And we know that this Lutathera treatment, even though it's new, can be safely administered in the proper setting. So that is the end of my talk, and I'm happy to take some questions. I am going to look at the chat box. Somebody was just signing off, and please send me any questions if you have any. We have another 15 minutes,